Welcome back from the break, everyone. Next, we'll switch things up and move into the first of two Catalyst Awardee focused panels, Healthy Longevity Across the Life Course. We are very fortunate to have with us as moderator and speaker Dr. Ritu Sadana, Head of Aging and Health at the World Health Organization. To frame this session, Dr. Sadana will share some recent and very relevant work of the WHO before welcoming on stage several global Catalyst awardees to share their research and engage in a discussion. So without further ado, let me turn it over to Dr. Sadana to get things started.
Thank you very much, Michelle, and also for NAM, National Academy of Medicines, to hold this event. We can just go to the next slide, and I want to say I'm very honored to moderate and introduce this session. This is really a celebration and a recognition of Catalyst awardees and what they have been doing over the previous years, and also an opportunity to learn and discuss advances in their work. Each of their projects focus on different life stages, including early childhood, adolescence, working age, and older adulthood, or some kind of intergenerational component. So before the awardees will speak to how their innovative work supports health throughout the life course, I'll start by giving a brief introduction on the WHO's new framework to implement a life course approach in practice. And then that will be followed by each of the awardees on how their innovative work supports this. This will be a discussion by the four individuals: Elam Beru, Yunjin Ho, Angela Narayan, and Vinod Prasad. Then we'll have almost a half an hour to have a discussion and a Q&A and to wrap up. So moving to the new framework, to next slide, please. Moving to the new framework that WHO has recently released. It's a framework to implement a life course approach in practice. And we have defined a life course approach to include a good start to life, optimal development of infants, children, and adolescents and youth, as well as adult health and well-being, healthy aging, and a dignified death at any age. And we believe that this framework considers how to put a life course approach in practice. It also summarizes current evidence to reorient health systems to produce health and well-being, drawing on examples from around the world on what is being done, and proposes next steps in light of evidence gaps and demands not only from ministries of health, but a lot of our partners in multiple sectors. And a key question it asks and tries to at least initiate an evidence-based discussion is what can be done differently? What are the innovations needed in order to implement a life course approach, given the current organization of programs within the context and situation of a country and the overall desire to have healthy longevity? Next slide, please. So one of the first things we agreed on, given a global framework cannot speak to the needs of a specific context or country, is what would be the criteria for a life course approach. And this is because a lot of WHO country strategies evoke the necessity to use a life course approach. Identified 6 principles promoting health equity, all the way to that the programs should ensure actions connect all life stages and critical sensitive periods. Next slide, please. Can you hear me? I'm just getting a message that you may have difficulty hearing me. Okay, thank you. So I just give one example of what do we mean by focusing on the whole person. And this is really important for the potential impact across the life course, and also considering that we're about the absence of disease, considering what makes up a good life. That's a basic question in terms of how do we frame well-being. In order to have life. And we use this person-centered approach that looks at a holistic approach of health capacities. Broadly, they cover physical, mental, and then social health and well-being. So we're considering capacities across the life course on cognition, physical movement, psychological capacity, a whole range of sensory capacities, also, to what extent individuals are thriving, which is often used for children, or having maintained, often considered for or older people, and also age appropriate capacity in terms of people's choices as well. Clearly, there are other capacities than WHO has a longer disability and health. In terms of these abilities for well-being, what makes up a good life, key areas include a person's ability to have agency and resilience, obviously to meet their basic needs for food security, housing, and healthcare, to contribute to families and communities, to continue to learn and increase competencies over their life, getting to where they want to go, having relationships and being connected. And there are other sort of diverse areas which are more specific or that can be important for some people, but these are the areas where we have agreed are the most important in terms of a generic approach to try to advance on what do we mean by a well life, not only a long life. Next slide, please. So just bringing this together, what this slide shows is ways that we want to identify interventions to optimize health, those capacities, as well as those abilities for well-being, and to be able to document them across a person's life. This slide shows that the level along the vertical axis and life stages along the horizontal axis are not just age groups, but also critical and sensitive periods that offer strategic development and reserve building opportunities. What connects a person over time is physical and mental health. Again, not simply the absence of disease, or their opportunity and ability to experience well-being. Certainly, genetic inheritance matters, but the environment matters depending on the issue between 50 to 75%. So a life course approach is informed by what happens in each life stage that has relevance for the next and future life stages and for the next generation. So we know that early risks to health and well-being, for example, in adolescence, are associated with 70% of preventable deaths from non-communicable diseases in adulthood, including 50% of mental health illnesses that are established by age 14 and 75% established by age 24. And that explains something like almost 15% of differences and physical and mental capacities among older people. But early action is impactful even in later life stages. Physical activity after the age of 20 is associated with better life, cognition, particularly for episodic memory and verbal fluency, and prevention of locomotion limitations. There's a lot more evidence on ways to consider risks, exposures, and strengths, because we know that these accumulate depending on the model across the life course and can impact health and well-being. So our new report collects evidence on these impactful interventions, such as baby-friendly hospitals that can mitigate low birth weight, or at the other end of this life course, comprehensive assessments of older people to detect as early as possible potential declines in physical or mental capacities. And there are many others that are highlighted also on this slide and in the report. But, the question is, what can be done with this knowledge so that these disparate evidence-based interventions and innovations can be invested in and implemented and reach all people who could benefit, whether through universal programs or targeted interventions to those who are at risk, or develop these with other sectors that reach people where they work, learn, play, and live. And of course, we also need to learn from each other and fill in evidence gaps. So that's what we can do, try to link optimal development, build reserve capacities, and maintain health and health, sure that people experience well-being. This is really important. Populating the length of life over 60 years is expanding in every country. These are precious years where we can redefine what it means to be human and humane as part of the life course approach, where we again want to increase health span, not only lifespan. This is really key to longevity that simply doesn't tack on these extra years at the end of life. So if you can move to my second to last slide. We also have a heuristic framework for action. And I think here it's really important to note that we link a range of social or broader or root determinants, structural determinants, intermediary determinants, and also proximal determinants. So we know that there are many different entry points for action. In WHO, we had a recent discussion between member states where we clarified to foster healthy aging and longevity across the life course, we would do three important things. One, we would continue to build up the evidence that directly addresses the needs and rights of current older people. Very important, given the UN Decade of Healthy Aging, which we are now at the midpoint, and we want to ensure the right to health of older persons right now. We also want to learn from interventions and programs for earlier age groups that can be potentially applied to older cohorts. For example, WHO's earlier, you probably maybe heard about the program on integrated management of childhood illnesses that packaged a range of services. This inspired our program on integrated care for older persons, not in terms of the actual services, but the approach to coordinate and package. And third, which I think is really relevant to this session, is we want to clarify evidence and also identify new innovations from around the world on what can be done in each age group that does provide cumulative benefits as people develop and age. So I'll just turn to the almost last slide on, if you can go to the next slide, please, on how this framework can be used. It can support implementation of existing strategies that call on the use of a life course approach. It can identify evidence-based services for each life stage, because we do have an evidence review in that area. We can also support contributing to the objectives of universal health coverage, which is a key component of the Sustainable Development Goal 3 on health. And it can shape investments and other support within the health sector and beyond to optimize health trajectories, considering where people live. And I think this is really where the Healthy Longevity Catalyst Award winners have an important contribution to make, because their projects focus on new research to extend the human health span and work across sectors. And I understand that NAM defines innovation as the extent to which the proposed ideas challenge existing paradigms and employ new methodologies or concepts. Next slide, please. So now I'd basically like to turn over to one by one to each of the Catalyst awardees, and they will give a little bit more background about each of them, and then also provide an overview of their project, what stage it's in, what's innovative about the project, and how it supports the life course. So if we can start first with Elam Beru. Thank you very much.
Thank you very much, Ritu. Good afternoon, good morning, everyone, depending where you are. I'm a senior lecturer in prescribing at the University of the West of England, but I'm also a clinician. I work part-time in a GP practice, a primary care centre, and I mainly prescribe or look after people with diabetes and high blood pressure. For years, by the time I see people who are coming to the GP practice and they need medication, it's a bit too late. They need their statins or they need their blood pressure medication. And I always knew that there was so much room for intervention before they come to see me to perhaps, negate the need for them to see me and prevent those conditions from developing in the first place. I worked in GP practices in the most deprived areas in my locality. And there's a lot of misengagement and people mistrusting the system, and people also struggling to access the system, struggling to access appointments and support and care. So I jumped ship. I got a UKRI grant, a healthy aging grant, and I worked with a community organisation in Bristol in England, and we trained them to use point of care testing equipment to test people in a community setting, in a shopping centre, in a community venue, in the gym, to test them for high blood pressure, HbA1c, to monitor for diabetes, total cholesterol profile, and many other tests. We provided the training, and they run the clinic from A to Z. It was a pop-up clinic in the most deprived areas in Bristol. People come in without an appointment, and they get their tests done, and they get their results there and then straight away, and they get them explained in their own language, in their own setting. And then we started to invite NHS services or primary care services to come into the community clinic and deliver vaccination, MMR vaccination, COVID vaccination, flu vaccination, etc. And all of a sudden, people started to engage more with their health. Over a 6 months project, we managed to screen over 500 people, and 55% of those had high cholesterol and didn't know it. 32% had high blood pressure and didn't know it, and 13% had pre-diabetes or diabetes and didn't know it. Most importantly, people who were resistant to vaccination, MMR or flu vaccination, all of a sudden, with a simple conversation from those community workers, were accepting of the vaccine and were vaccinating their children against those conditions. So it's the community clinic was informal. It was in a space that is less intimidating, and the community clinic was for everyone, irrespective of age. So people were bringing in their children, their elderly parents, or the people they care for in their homes, and it was accessible compared to the GP practice where I was there waiting for people to come in, facing a lot of resistance when I'm starting to prescribe statins, etc. And that opened up space for a further award from UKRI for an accelerator award, because when we were in those deprived neighbourhoods, what I realized is that there were many other community organizations offering other services for mental health support, for physical activity, for cooking classes, gardening, and all sorts. The problem is people didn't know that these community organizations exist and didn't know that these services exist, and most importantly, didn't know that these services are free. So with the second award, then we developed an online platform that supports people to look after their health and signpost them to the local free support services offered by community organizations within their postcode or zip code area. And this project is still ongoing, but we just launched the website in August, and it was just in my area to start with. And we already have around 270 average daily visitors to the website and linking to the community organizations that we listed there. The point I want to make across is that we need to be moving away from the traditional siloed models of providing care. So I'm a specialist in just diabetes and high blood pressure. I cannot prescribe for someone else with a different condition. And people have to book different appointments to see different specialists, and find spaces intimidating, find booking systems intimidating. And if we move away from that, and we move that care closer to where people are and make it as accessible as possible without boundaries, without too much worrying about appointments and booking systems, etc., and work with agility and work with people who know those people in the best way, we will be able to achieve targets and achieve outcomes that whole healthcare systems can't achieve with a lot of resources and a lot of effort. So yeah, I'm going to post in the chat a link about if you wanted to know more about the Sherry project and what the community clinic looked like on the ground. And if you wanted to visit our website later on to get an idea about what this categories of support that people are after, that are signposted to within their localities, you're more than welcome to. So I'll post that in the chat as well. Thank you very much.
Thank you very much, Ilham. And I think some of the key points you raised about having a comprehensive assessment so you can actually understand what are the risks or conditions that are undiagnosed. Also really working at the community level, which is primary care level, in terms of also being able to support the outreach to all people, and also not be in a siloed approach, but also not only in the health sector, but also understanding the range of social support that people can have. Very rich findings. I will now turn to Yujun Ho to give us a brief overview of the project that has been working in China. Thank you.
Thank you, Dr. Sadana. Hello, everyone. I'm Yujun Ho from Tongji University, China, and I have been a postdoc in NIH for more than 5 years. It is a great honor to be here as a recipient of the Global Healthy Longevity Catalyst Award and to share with you our project. And the title of my work is Multi-Target Mechanism and Application of the Small Molecule Compound PL402 in the Treatment of Alzheimer's Disease. Alzheimer's disease, AD, is a devastating neurodegenerative disorder. Worldwide, around 50 million people are living with AD, including nearly 10 million in China. It not only impairs memory and cognition, but also places a tremendous burden on families and society. Unfortunately, the benefits of current therapies remain limited, and some newly approved antibody drugs are associated with significant side effects. This highlights the urgent need for safer and more effective strategies. Against this background, our team has developed a novel compound, PL402, derived from natural products. Unlike traditional drugs that act on a single target, PL402 exerts multi-target regulatory effects. In mouse models, PL402 significantly improved learning and memory, social behavior, and anxiety levels. At the same time, it reduced amyloid beta deposition, lowered inflammation and cellular senescence, and promoted neurogenesis and mitophagy. Mechanistically, it suppresses abnormal activation of the cGAS-STING innate immune pathway and may also exert long-term effects through epigenetic modifications. Our research focuses primarily on the elder stage, where Alzheimer's disease is most prevalent. At the same time, we're also investigating how PL402 modulates aging-related mechanisms more broadly. This raises the possibility that early intervention on inflammation and epigenetic dysregulation during aging could reduce dementia risk later in life and help extend the healthy lifespan. And we think the innovation of PL402 lies in some aspects. It is a safe natural product derivative with low toxicity and facilitating future clinical translation. And it adopts a multi-target synergistic strategy, regulating both immune pathways and epigenetics, thereby overcoming the limitations of single-target therapies. And it not only provides a promising candidate therapy for Alzheimer's disease, but also opens new perspective for integrated interventions in aging-related disorders. So far, we have accumulated encouraging data from animal and cellular models. And next, we will use brain organoids and clinical samples to further validate these mechanisms and efficacy, while actively advancing industrialization and clinical translation. And our hope is that PL402 will bring real benefits to patients and also provide inspiration for the field of healthy longevity research. And finally, I would like to emphasize that AD is not only a medical problem, but also a social challenge. And through scientific innovation, we hope to alleviate suffering and extend the healthy phase of life. And I am very much looking forward to exchanging ideas and with fellow awardees from diverse fields and also working together towards the global goal of healthy longevity. And thank you so much.
Thank you very much, Ujan, for that really concise but rich overview of your work, and quite promising in terms of your results so far on impacting learning, memory, social behaviors to potentially altering the epigenetic effects. I think it's very interesting. You're focusing on what could be early interventions that are evidence-based, which is really promising because so many older people are trapped in focusing on getting a better diagnosis, but then not really knowing what can be done, and shifting the dialogue to what can we do as early as possible to improve people's lives and potentially shift the whole population curve is really promising. So thank you, and look forward to more of the conversation. I now turn to Angela Narayan.
Hello, my name is Angela Narayan, and I'm an associate professor of clinical child psychology at the University of Denver in Colorado, in the United States. And I'm also a licensed psychologist, where I conduct therapy and psychodiagnostic assessment for individuals in the community. My project is titled Positive Childhood Experiences to Counteract Childhood Adversity for Healthy Longevity in Marginalized Communities. And I want to just give a little bit of background leading up to my idea, which is that, you know, for the past 25 years or so, the fields of medicine, psychology, and public health have emphasized the links between childhood adversity on adulthood health problems, including poor longevity and earlier mortality. This has been done with the seminal Adverse Childhood Experiences, or ACEs, studies that were conducted by the Centers for Disease Control and Prevention and Kaiser Permanente in the US, starting in the late 90s. This research was groundbreaking in that it showed that higher levels of childhood adversity, so psychosocial risk factors of childhood, were linked to greater risk for health problems like cardiovascular problems, obesity, cancer, diabetes, chronic pain, and even earlier mortality. So this ACE literature really shaped a powerful narrative that we need to prevent ACEs in children to reduce the risk for lifespan health problems. Unfortunately, however, as this message has been disseminated to the community for the past 3 decades, this narrative takes a doom and gloom approach and is often misrepresented as those who experience ACEs will have poorer health outcomes and premature death. And my work focuses on the issue that this narrative is overly deterministic, pessimistic, and harmful, particularly to minoritized, marginalized individuals who have experienced higher rates of ACEs due to structural racism and systematic oppression. I want to change the narrative so that we all consider the role of positive childhood experiences in counteracting the effects of ACEs on negative health outcomes. So my goal has been to challenge this paradigm shift of childhood ACEs beget adulthood stress and distress to instead be, in spite of ACEs, positive childhood experiences promote long-term resilience and healthy longevity. Because in the original studies put forth by the CDC and many thereafter, the associations between ACEs and health outcomes were often only modest in size, which indicates that many individuals have high levels of ACEs but do not go on to have health problems. And so one main reason for this is because they also had positive childhood experiences in their lives, which counteracted the effects of adversity on health problems. In all of the ACEs studies, however, only 2 have ever looked at the role of positive childhood experiences in counteracting childhood adversity. And so my project is really in line with this idea that we need to promote lifespan and intergenerational health and longevity. So what I've done is I developed the most widely used instrument to assess pieces, which is called the Benevolent Childhood Experiences Scale. I'm going to show it right now just so everyone knows what I'm talking about. And this scale has currently been used all over the world. It's now translated into over a dozen languages, and it's a very quick way to assess adults' positive childhood experiences from when they were younger. So it's a freely available instrument. It's in the public domain, and it was developed to be a counterpart to the Adverse Childhood Experiences checklist. I'm going to stop sharing right now. I just wanted to give a little example, but this is something I can email to anyone who's interested. What we're doing in my project is, for the first time ever, we're looking at the links between positive childhood experiences and positive life outcomes, including lower risk of health problems, greater life satisfaction, and healthier longevity. So I'm recruiting a multi-generation sample of adult women and their own mothers to come in and tell us about the extent to which they've experienced these positive childhood experiences in addition to many forms of childhood adversity. So that includes things like childhood abuse and neglect, exposure to violence, racial discrimination, etc. And we really focus on recruiting individuals who are minoritized or underserved so that we can understand how do positive childhood experiences promote resilience in the individuals who need it most and the individuals who are under the most stress. And so far, this study, which I wouldn't have been able to conduct without this amazing funding, and I'm very grateful for it, is showing us that, first of all, individuals really enjoy being asked about their positive life experiences. In a lot of research on stress and health problems, we often forget to ask people what's gone well for you along the way, what's helped you. And the beautiful thing about positive childhood experiences is these are resources that people already have. They've already had a safe caregiver, a close teacher, friends that care about them growing up. The opportunity to reflect on these, oh my gosh, that really helped me along the way and that helped me overcome hardship, is not a practice that we usually do in public health or healthcare. So we're looking at the protective effects of these positive childhood experiences on adult women and their mothers, aging, healthier longevity, and many, many different health outcomes. So I'll pause there, but thanks so much for your attention.
Thank you very much, Angela. And I think the what you have described in terms of flipping the ACE studies to, rather than looking at what produces disease, but what produces health, is very much the mindset that needs to be put into place to identify how we can have longer health span, rather than only be concerned about, which is important, given the inequity still in the world in terms of lifespan. I think that the idea of really making this greater awareness is important, and somehow connecting that with the research around the development origins of health and disease, which also tends to focus on the disease.
Exactly.
I think that would be an interesting way to also advance. But let's get to that in the discussion.
Thank you.
And right now, I'd like to turn to our fourth awardee, Vinod Prasad. Vinod, the floor is yours, please.
Thank you, Ritu. Greetings to everyone from Singapore. So my name is Vinod. I come from a very different background from the other panelists. It's very interesting to listen to the clinicians' perspectives. I'm a computer engineer. I work in the Infocom Technology Cluster at Singapore Institute of Technology. And this project is funded by the Ministry of Health, Singapore. So it started with one of my main research areas is brain-computer interface. So the brain-computer interface, or in short, BCI, is a technology that will allow to acquire the brain signal, to decode the intentions of the brain or the signatures of the brain, to analyze your mental task, and to interface that with an external device, depending upon what application we want to do. So two primary research focus areas using BCI that I am addressing is one on enhancing the cognitive skills. The other one is to enhance the motor skills. So primarily on mild cognitive impairment or early stage dementia patients from the cognitive skills perspective. From the motor skills perspective is primarily on stroke patients. So in this project, what we do is we develop a brain-computer interface-based game which can be controlled by the elements of attention and working memory derived from the brain. So we have a brain acquisition system, which is electroencephalogram, which has only 4 electrodes, which is a portable user convenience system, which will acquire the brain signal. We analyze the features corresponding to attention. So when I say attention, we look at 2 different kinds of attention. We look at overt attention as well as covert attention. And we also look at working memory, and we integrate these features correlated with the attention and working memory to a game, and the game element can be controlled by these features. So how it started, we have already developed such systems for healthy people. It gave good results. So I was talking to my co-PIs in the Institute of Mental Health in Singapore at the Department of Geriatric Psychiatry. So, and they do have quite a number of MCI patients, mild cognitive impairment patients. Unfortunately, there is no pharmacological solution for MCI at the moment. So they are left untreated. And in Singapore, the population of MCI is about 12.5%. The global prevalence is about 23% among the geriatric population. And many of these cases could progress into the problem that Eugene was mentioning, a dementia or maybe Alzheimer's case. So our goal is that using this BCI system, can we develop a neurofeedback trainings system that will help to slow down the deterioration of the cognitive functions? And by exercising this game, they could do that. So the 2 games that we developed is, one is a car racing system. So we have a virtual car, and the speed of the car is controlled by the overt attention of the player. So the player is asked to focus onto the screen, focus onto the car, and depending upon the level of attention, which is derived from the EEG on a 0 to 100% scale, the speed of the car is proportional to the level of attention. And we also give a real-time feedback, a visual feedback of the attention on the screen, 0 to 100%, which is called a neurofeedback. So with the help of neurofeedback, the player will help to improve the self-regulation of the brain, to improve the attention, and to increase the speed of the car. So the objective of the player is to reach the destination fastest possible time. So that's one part on the overt attention. The second part is on covert attention. When the car racing is in progress, we introduce some distractions. So we are looking at how these distractions are affecting the overt attention, how much the attention drops. And once we take off the distractions after a few seconds, how much time it takes to restore the original attention level. And at the end of the game, the players were asked to recall the different distractions, the images that appeared. They have to list it. So it's basically the working memory. And the third game that we developed is we display an image. The image will have several objects, and that will be the observation phase. The player will observe that image. He is expected to memorize the different objects in that image. After that, the image will disappear, and then we will display one item, one object on the screen. That object may be an element in the original image or may not be an element in the original image. And the player has to recall and say yes or no. So to get yes or no on the screen, the player will have to raise the attention above a predefined threshold. And once that exceeds, the two choices will appear, yes or no, and the player can click yes or no, and the game progresses. Now, all these games can be quite personalized depending upon the level of cognition, working memory of the player. We can progressively increase the difficulty level and challenge the player. So the preliminary results show that when they do this session several days, the objective scores are improving. So that's one of the important observations that we have obtained. And so it's an ongoing project. We are still working with the patients, and our end goal upon successful completion of the project, what we envisage or dream is that every elderly people in Singapore, or maybe in future all over the world, could buy such a system and practice this kind of cognitive exercise at home, similar to people do some exercise in the gym. And so by continuously exercising this, they could sustain the cognition skills. So on the future plan is on a large-scale deployment at home, and this is actually in line with the government, Singapore Ministry of Health, or even most of the country's government's goal is to shift the care from hospitals to home, or maybe to the daycare centers. So the hospitals can be freed for acute care. So this is in line with that. And we look forward for the successful completion of the project and for the massive deployment, hopefully. Thank you.
Thank you very much, Vinod, for this very exciting study and development that you're engaged in. I think the evidence you cited of a 12% in Singapore and 23% globally in terms of mild cognitive impairment underlines the opportunity of improvement as people do continue to age, and the intent to slow down further declines is very much in line with what every country and family and individual is also interested in. So this alignment of all the goals from different perspectives, I think, bodes well for something that does actually show the evidence. Before we get to the overall discussion, I'm really curious on not the difference in results by men and women, but the feasibility in terms of enjoying this by this activity by men and women. And of course, what are some of the ways that you are thinking where as an individual scores improve using the game, how are you benchmarking that with implications for their daily life? So those are just some thoughts in terms of what you've so nicely described. I would like to come back to Elam as she's had a longer chance to hear everyone else, and start off with maybe 2 sets of questions. We have about 20 minutes left, so we do want to leave some space, I think, for a question or 2 from those who are listening. But if you could either have a question to one of your co-awardees, or if you could reflect on how you believe your work could influence health across different stages. I know that you described a community-based program. We didn't go into much detail about differences across life stages. Thank you. Elam.
Thank you very much. So thank you to all the panelists. Very interesting work, and it's all hopefully for the benefits of multi-generations of people who would benefit from this research. So I have a reflection on the applicability of this to multiple generations. So as I sit in the clinic in my GP practice role, I'm looking at people over 40 with a diagnosis of blood pressure or high cholesterol. once I stepped out to the community and started looking at that, and obviously I've been in the clinic, I've been seeing people with diabetes and hypertension a lot earlier than 40. So our public health programs capture people from 40 onwards. But if you happen to be a minority ethnic person or have other lifestyle risk factors or genetic factors, the program doesn't cater for that. We wait until you're 40, and then by that time you would have developed the condition already. But when I stepped out of the community, so obviously I encountered a lot more people who with high blood pressure, with type 2 diabetes a lot earlier than 40, some in their 20s and in their early 30s. But what I realized as well in that obviously these conditions are a lot related to lifestyle. And I starkly realized that obviously we don't inherit just our genetics, but we also inherit our healthy habits or our cooking habits. We inherit the food we like and how we cook it and the nature of interactions that we have with our communities. And a lot of those were okay a long time ago, 20, 30 years ago, when lifestyle was different, where we lived in different parts of the country and we did different things. And unfortunately, these are catching up with us now. And if we can't change our genetics, we need to change that inherited way of doing things, which is quite hard to do, actually. So, which requires a multidisciplinary approach. I can't solve that with a point of care testing equipment and train people to eat healthier and better. I need housing people to think about housing designs, city planning to think about where they grant licenses for people to do takeaways, and junk food. So, for example, one of the clinics was based on a street where the clinic is here, and then by the time you get to my clinic, it's like 3 takeaway shops, and you go past the lovely smelling chips, fried food before you get to the clinic, and then it's very hard for me to convince you that this is bad for you. Or and some people couldn't afford, actually, whatever I was talking about, couldn't afford to apply that even if they wanted to because of affordability issues. So it's very, very complicated, and health is rarely about health. It's about everything else everywhere, where the conditions we live in and interact with, and it's very tiny bit about it is genetics and health.
Thank you. I mean, I think a lot of the work on social determinants of health tries to make it clear that in order to put all people on a better trajectory, to level up the equity of individuals, is that they need to have the opportunities. You can't just expect people to choose health or a healthy lifestyle if those choices are not available near them. There is perhaps an intergenerational aspect as well. I'm going to turn to Yujen and ask her, given the study and your compound PL402, and you've been focusing on AD, but you've also mentioned many different aspects of what this could be beneficial for. Have you considered other aspects in terms of besides older adults? Just curious to understand your view on that. Thank you.
Yeah, thank you for the very good question. So we know that Alzheimer's disease is mostly for the elder people, but unfortunately, there are so many people they have the Alzheimer's disease before the 65 years old, and especially if they have the traditional transgenic genes such as APP or PS1, they will happen very, very early than that. And so that means our compound maybe not for the late onset or the early onset Alzheimer's disease, but also for the generally aging population. And because PL402, it have a multi-target compound, it not only decreases amyloid beta deposition, but also has the anti-neuroinflammation effects or some neuroprotective effect. So that may help people to have a very good lifespan throughout their life. And also, very interestingly, we found that this new compound, it has beneficial for our mitochondria. So now mitochondria is very important for not only for nucleus, but also for the whole life. So we found that this compound also can increase this autophagy, that is mitochondria autophagy. So through this mitophagy activation, it can decrease this mitochondrial DNA release to this cytosol, and then they decrease the SIG-STING activation, and then eventually it can decrease this cellular senescence and also the very abnormal neuroinflammation. So we think that this compound not only for the general Alzheimer's disease, but also for the MSI, just we not mention that, and also for the general aging population. Thank you for your question.
Well, thank you. I have a question for Angela. You described the next phase of your study very much in the area of looking at, you said mothers and daughters and the intergenerational effects. Could you be a little bit more precise on some of the hypotheses you have for this next phase? Thank you so much.
Yes, of course. So the hypothesis that we've seen in many other studies where we've looked at mental health outcomes in our work with positive childhood experiences is that we will expect that these positive childhood experiences in adult women and their own mothers' childhoods would buffer or moderate against the effects of their childhood adversity on their better physical health outcomes. So this is the first project that I'm aware of that looks at physical health outcomes and healthy longevity as a consequence of both childhood adversity and positive childhood experiences. And I wanted to just make the connection to what Ilham said about so much about genetic heritability is inheriting the healthy outcomes in addition to the negative health outcomes. And, this project I'm doing really has intergenerational implications because we know from a social determinants of health framework that the social capital that we have, like positive relationships and support in our families and communities can really go a long way to sustain healthy development. And in terms of social policy and health policy to prevent health problems and adversity in the next generation, I really see, one arm is ACEs prevention in the next generation of children. But we also need to not forget about the children's parents who have a history of their own childhood trauma, often in their own ACEs, and they're forgotten in those efforts. Another effort, of course, is to reduce systemic inequities in the first place, which is a great endeavor, but not something that we could do immediately. What we can do right away is we can help adults who are parents think back and harness and leverage the positive childhood experiences that they had so they can reflect on them and create positive experiences for their own children. So thinking back with parents, we often say, what was the name of a teacher who was really your champion in school? Even if you didn't like school and that was a hard place for you, what was the name of the teacher who really supported you? And the vast majority of adults in all of our samples can name at least one teacher who was in their corner, or at least one person who was supportive in their life and safe, even if it wasn't a biological parent, it was maybe a foster parent or an adult relative. Those are resources that people have in their possession, and we can leverage them across generations to create templates for healthy caregiving of children.
Thank you. I know we don't have time for you to respond, but I am curious, what about the fathers and daughters or fathers and sons or mothers and sons? Not to forget those other relationships as well.
Of course.
Vinod, I already asked a couple of questions, so maybe I don't need to repeat them and you can give us a little bit of insight. Again, I'm not interested in the differences in the results between men and women, but on this feasibility and interest and then the potential application to their daily lives to make it meaningful. Thank you.
Understand. Thank you. That's a very, very important question. I mean, there have been a few studies in this area to evaluate whether there is any difference in the performance or efficacy between men and women, and there's no conclusive result so far, even though some studies did report that women have slightly better cortical connectivity. But still, it's not a conclusive study. Now, in the second point that you raised is extremely important because that questions moving this brain-computer interface system from lab to the real world and efficacy in the real world. That is yet to happen. Actually, we have done some studies where we try to mimic real-world situations through virtual reality games. For example, this MCI patient, we create a home scenario where the patient is supposed to navigate in the house to accomplish the daily task in his life, the routine task, whether it is getting up in the morning, after getting up, brushing the teeth, or having a cup of tea, taking the medicine, all these things. And if he has to navigate that through, he has to use his attention, working memory, motor skills, right? Which is decoded from the brain signal using brain-computer interface. So it's a combination of both cognitive and motor skills, which he will have to apply, which is interfaced through this BCI technology to navigate in a home environment, which is a mimic situation. It's not a real home environment, it's a virtual reality environment. But that preliminary study shows some promising results. But coming to the point that the actual translation of that into a real-world daily practice is yet to be investigated. It's not an easy task. But the hypothesis in this study is that once they practice this in a virtual reality environment, they are expected to perform better in the real world. But I do admit that the technology and the research is still not out there, that stage. But that's the future direction. Thank you.
Well, thank you. I think the key is that we have to try different pathways towards our goal. And I think that's what's really exciting about the program that the National Academy of Medicine has put together, because it's only through this research and innovation can we hopefully come up with those new impactful ways to address these issues. We do have still a little bit more time, and I don't know if there are any questions from the audience, or if we can continue discussing amongst ourselves. I would really encourage now if I could ask each of you to ask one of your awardees a short question. And I'm hoping we could do maybe 2 rounds so everyone gets at least one question, but something really short. And I'm not going to tell you what to ask, but if you could frame it so we can have a quick flash response. So I'm going to go in the reverse direction. I'm going to ask Vinod first to ask anyone he would like. Vinod, please go ahead.
Thank you. Thank you very much. I think I will probably not ask or share this suggestion with you, June, because she is working in the advanced phase of the work that I have been doing. And the early phase is what I'm trying to do, and the advanced phase is what Eugene is doing. Have you thought about supplementing or complementing your pharmacological intervention with some technology that I'm talking about? A combination of these two could probably, do you think it works better? Of course, I know that it's not as easy to, in the case of Alzheimer's disease, because it's quite an advanced stage as compared to MCI, but still, will there be a possibility to explore that? And do you think that that kind of a hybrid approach might help?
Yeah, I think that's a very good question. And I think it will be better to combine yours technology and with maybe not my compounds. And I think that will be beneficial for even MCI and early Alzheimer's disease. And just as Ritu just mentioned, that prevention or have good biomarkers will be better than just treatment. So I think that's very good, suggestions to do that.
Thank you. Thank you.
Angela, it's up to you. Who do you want to ask a question or a comment?
Yes, thank you. I will ask Ilham. I was fascinated to hear the work that you described working in the clinic with the families who come in, and they vary in the extent of resources that they have, and you're really trying to help them with psychoeducation about healthy behaviors. What are the strategies you find or the messages you find most effective in maybe shifting how they think when you only have a small amount of time with them, obviously, because they are busy and they have other basic needs that they're trying to fill? what works the best?
I think what worked really well was that me and other people who were working in the community clinic understood exactly where people were coming from. And I mean the religious, cultural aspect. So in my GP practice role, I would say I would talk statins, and this medication reduces the risk of stroke and heart attacks. In that clinic, I would say, you know, we have a duty in this particular religion or context to look after our health. And if we are not very well, we can't, the woman is the pillar of the family. If she's not very well, she can't look after everyone else. And this appeal to them, it's completely different to what I do in the other clinic, but it required me and my colleagues to speak the language of where people come from. And this made more sense to people than a statin will reduce your risk of heart attack and stroke by 10% or 20%, which wasn't working for years. So that's why the resources that we have to leverage or delegate this task to people who know, people who the best, they can speak their language, they know where they're coming from, they know where they're going back to, and they can convince them their own way.
Thank you.
Yujun, do you have a question?
Yeah. So I have a question ask Angela, and I'm so interested in your work, and I think that the positive childhood experience is so important. And like us, we are also parents, so we have young children. So like, do you have some things to tell the young new parents? So how to treat our children is better, and which behavior is not good for them? Thank you.
Thank you. I love that question. And as I've been conducting this work, I've become a parent myself. So my kids are now 4 and 6. And so it's great to think about, practicing what you preach. So I think for all parents, we take the things from our own childhoods that we really thought were helpful, and then there might be some things that weren't as helpful. And so being really aware and intentional of what I want to repeat and what I don't and why. The awareness is the first step in the insight. And then the next step is having the templates to recreate what you want to recreate. And so I think this is where my work comes in, is it gives people an idea to think about the things that you want to recreate. It starts the conversation with, think back to a really safe caregiver you had, or a really close friend, or a teacher who cared, or good neighbors, or another mentor or role model. It gives the initial idea, and then providers, health educators, school personnel, they can continue the conversation, but the seed is planted. One of my mentors who developed this instrument with me said, parenting gives us another opportunity to redo our childhoods, and we need to take advantage of that. So I think as parents, we have the opportunity to take advantage of that.
So good. Thank you.
Thank you. Elam, a quick question, if that's possible.
Yeah, this super quick question to Angela as well. The work is very interesting. This bank of good is fantastic. And how can you see it expand into other areas beyond childhood experiences? If people are appreciating what's good in their lives and not necessarily just linking it to childhood, how can that help them live healthier and better?
We do a lot of research in my lab where we then look for cumulative resources across the lifespan and over generations. So the benevolent childhood experiences scale is just one tool focused on childhood, but we also do social support, and we do other adult resources like coping strategies and values, like you talked about, the cultural and the parenting values that individuals have about relationship roles in their families. So that's all part of the cumulative process of resilience.
Well, I really have to thank all of you, and also again congratulate you on being an awardee and for the foresight of the sponsor, both of your individual sponsors as well as the National Academy of Medicine. I think this has been a terrific learning and sharing session. And I think it also really makes clear how we can build up together evidence-based actions, take them together with people from different disciplines, and also support people of all ages as we try to increase health span. So I think we're just closing on time, and there will be, I believe, a 10-minute break. Thank you again, and I think I will try to see if I can clap my hands using this using the technology that we have. I'm looking to find it more. It's somewhere here. But thank you again, and a real pleasure.
Thank you.